Welcome back for session 7. We are delighted to bring you a live case from RIO course co-director Rod Tung and his team at the University of Arizona College of Medicine in Phoenix, the US, and I can guarantee you they never fail to put on a great case. The title of this session is Resetting the Rhythm, Cardioneural Ablation in Action. But before I hand over to Rod, let's meet the panel for this session. We are joined by RIO course director Devi Nair, Tolga Aksu from Istanbul, and Luis Carlos Saenz Morales from Bogota. Rod, over to you.
Well, thank you very much, Professor Schilling. It's great to be with you. Again, just confirm that you can hear us and see us okay?
We can hear you and see you perfectly.
Wonderful. We're going to have Dr. Fakhri, our second-year fellow, introduce the case, and we are already underway.
All right, everyone, thank you. This is Mir Fakhri, EP fellow here at Banner Medical Center, EP Lab 7. Here we have a 30-year-old female presenting as a consult to us with a history of diagnosed epilepsy as well as pre-syncope. She had a syncopal event on a tilt table test in Mexico, for which we don't have the results for, but we were able to reproduce with a tilt table test here, where she had symptomatic bradycardia and a syncopal event during the administration of nitroglycerin. Before, she has tried both midodrine and beta blockers without any help or curative effects. And so she presents now for cardioneural ablation. She's having increasing salvos actually, and just had one the other weekend, where she has bilateral arm numbness, feeling of dizziness in her head, and then is down for upwards of 10 minutes until she wakes up. You can go to the next slide. So here's her baseline EKG. Not very contributory, as you can see. No evidence of pre-excitation, normal intervals. And then the strip underneath is her episode of sinus bradycardia that she experienced mere seconds after the nitroglycerin was given to her during the tilt table test. And so far we've done a normal routine EP study with normal SNRT and C-SNRT, normal AV Winky-Bach, and AV nodal ERP.
So we're actually going to take you through a bradycardia study, which is so not in vogue. But let's take a look at a couple of things. Chris, if we can go to review. We first start with the EP study and look at a SNRT, and then we also look for Winky-Bach. So why don't we go ahead and just show the sinus node recovery time. And as we're doing that, case selection is critical, so it might be good, Richard, to just ask the panel about the quality of the case selection. We like to see a symptom-rhythm correlation. We know tilt is not 100% specific, but we do have nice junctional bradycardias that's provoked with a tilt. She's had syncope since the age of 20 for 10 years and has pre-syncopal episodes multiple times and has failed midodrine. So we felt like it was a good candidate, but I'm curious to see what the panel discussing, because I think case selection is so critical when we talk about compassionate off-label experimental therapies, which is what we say, all 3 words when we actually consent.
Okay, well, great. Let me put that question to Luis. Luis, do you have any experience of identifying these patients, and what techniques and tools do you use to do that?
Sure. So we're indicating the procedure in patients with repetitive episodes or of syncope. But what is still discussing inside our team is if in very symptomatic patients with with bad consequence of syncopes like injuries, etc., if we have to wait or not for medical treatment response, because it is supposed that you indicate the procedure after proving a medical treatment. But medical treatment seems to be more aimed to prevent vasodepressor responses, right? So it is a question also for the rest of the panel. If we also prove first failure of medical treatment, or do you indicate directly the procedure as we are doing.
Yeah, I mean, it's a good point. And I guess the reality is that many of these patients have gone through many of these treatments before they even get to us. But what's your experience, Tolga, of this type of patient?
I think the indication should be similar with cardiac pacemaker implantation. So we can use ILR or we can use still testing. And if there is just a cardioinhibitor response or dominant cardioinhibitor response, the medication will have no role. So first of all, we should try lifestyle modification and education. But if there is still recurrent and maybe traumatic syncope episodes, and the reason is dominant cardioinhibitor response, by using tilt or ILR, we can do CNA.
Yeah, I mean, I think that's a very good point.
Younger than 40 years old. This is a very important point because, there is no positive randomized control trial in younger population with cardiac pacing.
Yeah, I think that's a good point because one of the problems with loop recorders is, of course, the uneducated will tend to pace them when they see bradycardia, which, of course, is not particularly helpful for this patient group. Devi, do you use loop recorders very much, or prolonged ECG monitoring to try and identify these people, or do you use tilt tests?
So I will say that I'm using both in a sense. I have to say that, like Tolga said, one of the things is identifying the younger population, but I do have ILRs. So I have a way of, since it's so new, at least in my practice, this is only something that we have incorporated in the last year or so. So I want to see how these patients do, understand what I'm doing to them. Like Rod said, it's off-label, experimental, and compassionate use in most cases. So I think we have to have validation. And this is the only way if we collect data.
So let me pass back to you, Rod, on that original EP study, because I'm feeling a little bit nostalgic seeing a sinus node recovery time. It's been a while since I've seen someone do that. So can you talk us through your baseline EP study and what you're looking for in this patient?
Yeah, and in the US, we really just get authorization and bill for an EP study because, as we know, there are no billing codes for the cardioneural ablation. So here you have a very classical snert here. The absolute sinus node recovery time measured to the next sinus after pacing for a minute at 500 is 1.5 seconds. And corrected there, subtract minus 996, the corrected C snert is about 546, slightly on the upper ends of normal. Or if you stick with 450 or 500, it's abnormal. The baseline heart rate in this woman is that she's around 59 to 65 beats per minute. And here you can see there was a slightly abnormal C-snort response. One interesting thing is we typically think about snerts that are abnormal as something that is a fixed sick sinus disease. And I'd be curious to even ask Aksu what he thinks about how often C-snerts that are abnormal can actually change with CNA. Before we go to that question, let's say show Winky Bach. And during the drive train, when we were doing a snert at 500, the patient was already Winky Baching. But this is really pretty because what we have here is very, very long AH. And what's more intriguing is if you look at the CS1-2, and we use the decapolar catheter just to reach out to the His, you see there's another component. Yeah, that'd be great. Let's just hide that left atrial pressure. There's another component there that is sitting in there that could be a split His, or it could be a split A. And that was interesting to us because if it's truly split His disease, we wouldn't believe that that would be a good candidate for cardioneural. But recall that her primary problem is a sinus node problem and not really an AV conduction problem. As we go further down and we do A1, A2s, Amy, we can go to that. And so just before AV NERP, we show that she has dual AV node physiology with small echoes. Keep coming down. And we'll go to AV node ERP and the one before it. Keep coming down. Great. And there's AV node ERP. Great. And then go one before. And here is an A1, A2 with a ridiculously long AH. I should note that the sedation is only some slight propofol. We don't put them under general anesthesia because we still want some autonomics, but a ridiculously long AH. And you can see that that other potential that we were confused about is probably a split A, which is interesting. And that AH is 590 prior to AV node ERP. So I think that our C-SNRT's abnormal. I think our slow pathway is one of the longest. I think Josephson even said the longest he's ever said in his book was almost about 600. So we've got really advanced, maybe high hypervagatonia. And the question again is, how likely are we to change this after CNA?
Rod, can I ask you a question? Why would you think that this is not a junctional beat? And because she did have junctionals as, you know, on the tilt. And why would you think it's a long
Yeah.
AH?
Can we go ahead and just go back? So obviously you can't tell based on a single. Amy, just go back one at a time. Go to 310, and you'll see it's reproducible, and it prolongs and prolongs and prolongs, Devi. So I think it'd be rare right there. See, you see it? It's pushing out. So it's a great question, and we thought about that, but it keeps prolonging and prolonging. So I think it'd be rare for a JPB to keep coming at a later and later escape interval, that this is consistent with a very long AH. And we saw that with Winky Bach too, which was nice, is that with Winky Bach, she gets really long AH before block 2. But certainly in the differential. But it's cool that we're talking about Brady. It's cool that we're talking about a baseline EP study and even how to interpret that. But how often is this going to change? AV node ERP, how often will the slow pathway be modified, which we think could be a mechanism as to why slow pathway modification works? And how often does the C-SNRT normalize or correct after cardioneural ablation? Because I think the ablation part, which we'll talk about, is actually less interesting than the physiology and case selection and endpoints.
And Rod, the second A element that you saw on the earlier premature beats, what's your? They disappeared as the extras came earlier. What's your explanation for that? What's your phenomenon? How is
There's some interatrial block? Yeah, there'd have to be some weird interatrial block. We can show the weirdest thing, and I don't want to sidetrack us too much, but show a couple beats before it, Amy, again. Just go back. And you made the observation, right? But it could be catheter motion where you don't record it. Come forward again. Earlier again, earlier again. Earlier again, again. Earlier, again. There, look at that one. But take a look at you're doing your drive. You have a split A there, and that's probably too short to be an AH. And then you have a split A and then a hiss, and then you see this ridiculous latency. So I would think it's just the strangest interatrial myocardial delay with some sort of deceleration zone in that region. And then either you don't record it because it's not as sharp during the extra, or there's some block interatrial and there's have prolonged conduction. But you would actually think with that, you should have a lot of gap phenomenon, which is great to talk about as well. And therefore, if you actually think about the arrival at the latest A, the AH is not that long, but it still elicits a dual AV node echo.
I have a question for Rod. Can I?
Yeah, please.
Did you use atropine before the procedure? You know, try to understand if the patient will respond to CNA?
Yes, this patient is outpatient, so we did not use atropine before. And for those that have never undertaken a CNA, we don't want to give it now because that will mask some of our findings because of the long half-life of atropine. So we might mask a vagal response. We're not going to know what our target heart rate is. We like to see a heart rate increase of around 20 as our endpoint. That's quite arbitrary. But she came in at 60. I told her we're not done until she's around 80. And anecdotally, that's worked pretty well for us for this. But atropine is a great one for an inpatient that you're not sure is reversible or not. And if it all goes away, just like if you walk a patient, you give Isopril, you give atropine, then it really is a nice way to be able to determine, vaguely mediated bradycardias.
Good point. So I have a related question for Tolga. Based on some experts, it is supposed that if you use atropine before the procedure, in patients, in hospitalized patients, for example, if you produce a very, very intense increment of the heart frequency, that may be a predictor to induce inappropriate sinus tachycardia after CNA. So do you have any comment on some experience about this concept?
So very good question. Actually, post-atropine response will be not same before CNA and after CNA, because during CNA we also cause some sympathetic denervation, especially in the acute term. So, for example, before the cardioneural ablation in outpatient clinic, the resting heart rate was maybe 70 BPM level, and after atropine, it increased to 130 BPM level.
This is flushing.
But after the CNA, you cannot increase the heart rate to 130 BPM level, because you will also cause some sympathetic denervation.
Yay.
So you shouldn't be try to achieve pre-ablation atropine response level
0
during the procedure. This is the first one. And also, according to my experience, post-atropine response has no correlation with post-CNA inappropriate sinus tachycardia level. I think that the main reason of inappropriate sinus tachycardia is performing too high ablation in superior vena cava side. Because once we go to the higher part of the superior vena cava, we are also affecting aorta superior vena cava GP side. So it can cause some inappropriate sinus tachycardia during follow-up, according to our experience. Especially nowadays, we are using combination of 3D CT and 3D map, and we can clearly see all these epicardial fat pads and thickness of the epicardial fat pad in all area. So in the higher level, if we perform ablation, we can cause more sinus rate increase. And I don't think we need to do that.
Thanks.
So one of the important parts is, how do you determine where to ablate? And we've used to start with intracardiac stimulation, which invariably induces atrial fibrillation, but you can look at RR changes. You can certainly put something up the jugular and try to stimulate and see if you can see an extracardiac response. And Dr. Pachon has a stimulator he is developing and creating for that. We have had mixed results with being able to identify that region, and even with using a micropace and going to 50 milliseconds, which is typical 10 MA, we don't always see it. So we've kind of abandoned extracardiac stim because we don't have exactly the same equipment. And I do think it would be the best endpoint to have a switch to turn it on and then reassess. So what we typically do, and I've learned from Tolga Aksu as well, is go based on anatomic. Yao Yin has a study published in Circulation AE from many years ago that showed that anatomic is just as good, or non-inferior at least, in a non-randomized fashion with being able to provoke this. So we typically like to start from the left side first and then hit this LSGP region, which is really the junction of the roof and the left superior pulmonary vein. It would be nice to follow the fractionation map that we have here. And we have this just as more than 4 deflections that go up and down, which being in white, but we actually don't see much fractionation at this area is the LSGP. Anterior to that region is the Marshall Tract GP, which is really in that ridge. But if you rotate this anteriorly to the map, we can see that the expected area, the RAGP, has a lot of fractionation in that region. And whether that's pulmonary vein potential, whether that's truly fibrillar network from the neural integration or interlacing of neural tissue with myocardium, or if it's just because it's a septal structure and you're sensing RA as well as LA, we don't know. But this superior paraseptal GP region is famous for having these abnormal electrograms. We like to ablate that after, because we don't want to eliminate vagal responses. We enjoy seeing vagal responses because we feel like we're actually hitting a region that would elicit maybe what her clinical would be. Any comments on that before we initiate ablation at the LSGP region?
Tolga.
In our routine approach, we are starting with left superior GP, you know, Rod. But nowadays we are doing a comparison study by combination of 3D CT and 3D map, and we are just ablating epicardial fat pad area to compare whether we need complete GP ablation in all case. So after the result, maybe I can say some better thing, but for now, I usually try to ablate left superior GP. I'm very happy if I see bradycardia during ablation in that area.
Anyone else?
We are
have
also
any
very
comments on that?
happy when we see big responses.
So
By the
did
way,
you mention that?
can we
Just go
see
to
the
ice
peak
full.
frequency map? Can we see the peak
Can we change it
frequency
to a
map, for
peak
example, in
frequency?
300
It's
hertz,
better.
maybe 400 hertz? Whether there is any correlation with fragmentation and peak frequency? It will be interesting.
Peak frequency map at 300 hertz, please. Near field. So we have a request for a peak frequency map. We're going to work on that. Why don't you go right here? Let's go to 300 as requested by Dr. Aksu.
Yeah, and 400 and
That's very nice.
okay. Yeah.
There. But you're seeing gray areas as having lower frequency, right? And then you're seeing the Marshall tract having lower frequency than the high frequency, but you do see the red areas, right? That are somewhere around there. Tolga, you want to comment about how you're assessing this? Because there's a lot that are much higher than 300.
Actually, this is just for research aim. We are checking 300, 400, and 500 and try to find whether there is any correlation. So higher frequency level, maybe more than 400, seems better for left-sided GPs. And according to our experience, 200 between 200 and 400 hertz is better for right-sided GPs, but it's not same in all patients.
And
Always
Tolga,
So we are about to start.
Okay.
Go ahead, Devi.
Tolga, can you walk us through your pre-imaging? Like, what is your protocol for pre-imaging with CT?
So we are working with InHeart for that, for this study. So they have a protocol very similar with coronary BT angiogram, very, very similar. So they just send us to 3D map suitable images within 1 or 2 days. But I think that it can be easily done in our local radiologists. It will not be difficult because, you know, the issue is to tag the epicardial fat pad area in 3D maps, 3D CT. That's the point. And we are checking the thickness of the epicardial fat pad. And then we are trying to check the fragmentation on electrogram in that area. So it's very easy, I guess.
So,
I have
Tolga,
a
sorry, it's
comment.
the correlation of both the fat pad and the fractionation that highlights the areas that you're interested in. Is that correct?
Yeah.
I have a comment about location of GPs. We recently published a paper in Europace with Pasquale Santangeli, in which we collected 17 patients that underwent the procedure, but guided just anatomically by using ICE, intracardiac echo. So obviously the limitation is that we ablated just the paraseptal GPs, but the results were encouraged. The recurrency rate of symptomatic syncope or functional bradycardia was similar to other papers. So this is another way, especially in teams that we don't have the possibility to have CT aimed to segment the GPs and the fat pad. I mean, it is very easy to recognize the fat pad. So you have to advance the ICE catheter in the transition between the SDC and the right atrium and clocking, clock third. And in between the septal spot of the SBC, the right pulmonary artery and the upper pulmonary vein is located the fat pad. You can recognize the fat pad because it's echogenic structure. So the same is you can do the same for the inferoseptal, inferoparaceptal fat pad. So you advance the catheter at the level of the coronary sinus ostium. You clock, and you can see the fat pad in between the coronary sinus, the right atrium, the SBC and the inferior vena cava and the right atrium, the coronary sinus, and most anterior aspect of the right inferior pulmonary vein. So just to add to the discussion, it's another way to locate the GPT.
All right, so amazing discussion. We're going to start with the LSGP. If you just go to ICE full screen, Chris, just want to point out we're in the left atrium with our ICE catheter. So that's always nice to see. And you can see the appendage, how nice that is. You can see our catheter is above that at the roof. And as we clock just slightly, we can advance in. And what we do is we see a little bit of that LIPV and the LSPV right there. And this is the junction of that roof LSPV. I don't like to ablate in the vein, but often we find there's some big responses you get deeper in. So if you now go back to the map, you can see we're pointing up at the roof. I have a lot of respect for the roof, so I'm going to stay at single digits and probably just do 30 and inch up to maybe 40 watts, and then see if we get that vagal response. And note that there is not any particular fractionation on the ablation distal right now that has a little bit of overlap. Why don't you guys just gain down the CS so we could, and then maybe change ablation distal to yellow so we can see that. But we're monitoring this on ICE, and I'd like to see some increased echogenicity as we ablate there too. And we're going to stay on for about 5 to 10 seconds and see if there's any response. And maybe we'll see a great response here. So let's go ahead and come on at 30 watts, and then we'll ramp up to 40 watts in about 5 seconds if there's nothing. Okay? Go ahead and come on here. Starting heart rate is around 73. So it's not much change here. Go up to 40 watts here. Okay, and there's really no response there. Electrogram has changed off. Good. So in a way, we are trying to identify this based on the ablation response. Sometimes we will see great successes, even though we don't see much ablation response there as well. We do have some motion here with the respiration, so you can see that she's sensing some of this. Let's try right here. It's a little bit deeper in, although on ICE it's not. So the mapping system is just slightly altered by the respiration. Come on here at 40 watts, please. I'm at single digits contact force. Let's see here. We're at 73, sneaking in just a hair. 77, 78, nothing really going on here. And kind of moving around there, we got slowing. It might have been a PAC, so I'm gonna move just a hair because I don't want to burn too much in here. It could have been a PAC. We will review that in a moment, but it's not a significant response here whatsoever. I'm moving slightly anterior, and then I'm going to move. Okay, come off here because we don't want to do excessive lesions. Let's just go back and see that. Was that just a PAC with pause? Because if that's the case, there's nothing that interesting. And then I'm going to extend a little bit higher anteriorly. It was just a PAC. Yep. Nothing interesting.
So one of the things
ahead,
that
Debbie.
I have to say, I was saying is one of the things that has helped me kind of stay stable in that location is putting the ice in a kind of a transmitral location and looking up, so you don't have as much of an interaction and you can see the roof. So if you just clock your ice to the right superior and give it a nice posterior tilt. Yeah, if you have a neutral
This
position,
view here, Devi.
ice and clock it to it. So if you clock it where you can see the right, yep, that view.
There you go.
So you can see that, yeah, you can actually.
You can see we're just almost inside the vein, correct? And here you could get more to the roof side there.
Yep.
There. And you can see we're more on the roof side, more antral. And then the key here is that you don't want to start creating half a line either. So if I don't see too much response, I'm kind of done in this region, but this is different. And you can see with our PA, it's a different spot. I'm going to do a very brief lesion here and see if there's anything here. Let's do 40 watts here. Got about 6 grams of contact force. A lot of respiratory motion there. 73, 70, 72. Nothing of much interest here. We're sneaking inside. I don't see a lot of whitening though, so I don't feel like I have a great lesion. Okay. I'm at 40 watts. Is that right? Okay. 73, 74. Off, off. I don't want to do too much more in that area here. And then the thing is, if I go just a little deeper in the vein, I might go into the Marshall track and sneak a little anterior because sometimes that's there. Let's try this spot here. We're just doing 5 to 10 second test burns, but even there, I still think we're probably modifying these regions. PAC, nothing of interest. We're at 40 watts, correct? Okay. A little bit more force. Things are queuing out locally. And there you finally see some whitening in there on ice, but no significant big response. Off. Okay. Came down to 67. 68. That's like 2 beats. That's like nothing to really write home about. Let's go to the Marshall track here. And we know that we're going to get a whole lot of acceleration on the RAGP for the sinus. And as many people know, even a right-sided approach is still effective. Whether it's less effective or more effective, whether it's non-inferior to a left-sided approach, we don't know. But it can still be very effective. So here I'm more anterior here. And really we're kind of burning the ridge. And this is what's called the kind of the Marshall track. You could see in Devi's view that she's liking that we can sting the ridge here a little bit. Why don't we go ahead and come on here at 40 watts because my force is only 30. It's only 4 grams. Yep. Come on here. Let's just see if we can get this to go white and then see what we can see there. Mira, if you could just adjust here. We're just on this side here. Probably just the PAC. Slight adjustment. The local queued out. So we are creating lesions. There's some whitening of the tissue there. Some PACs, which are not helpful. Okay. 67 off. Okay. So I've kind of gone anterior. I've done to the junction. Gone a little in. Yep.
Rod, you're using 30 or 40 watts in a longer lesion just to really get depth. That's right, isn't it? Rather than high power, short duration.
Right. I'm just trying to do, and this is a young woman, so I'm trying not to go, above all, do no harm. So I'm just trying not to do something really big with 50. I'm trying to get more depth. So I'm trying to sneak up and typically go 30, 40. I'll spend 5 seconds doing 30, then 40. But I guess the question here is that we're not seeing that aha moment, but it doesn't mean this isn't going to work. We're just not seeing a profound response here. And the question is, would people do more here or start moving to the right anterior GP? But I feel pretty good that we've interrogated this with 6 different sites and not seeing any significant responses. The only thing that I would say is we're not seeing huge echogenicity. So I'm not impressed that we've made really great lesions. But again, I don't want to do too much here, but maybe we try one more at 45 watts here. Go to 45 there. Yep. And I'm just going to slide back from here, and then I'll take a poll if there's more to do.
Presumably,
Yep,
there's no role for PFA because although it causes a transient autonomic effect, it's not going to cause any modification. Is that fair?
Presumably, yes, but we know it's not nerve sparing because there's phrenic cases, but it should be less nerve sensitive. I'm moving just a little bit outside of this and just kind of moving a slight difference here. I'm not seeing a huge response. Typically, we already do here, filling in this region at the roof. Here, it's still 76, moving just a hair. Try not to do too much in this region. And off. I would move on from this region. Yep.
Can I ask you a provocative question?
Sure.
So if
Those are the only good ones.
dual energy, I know. If you had a dual energy catheter, would you consider a pulse field energy as a reversible, in more of a reversible fashion, figure out where you're getting the response rather than using RF this way? hopefully in that way you're not leaving behind any kind of scar. And then if you do have a response, then maybe go with RF on top of that. Would you consider that?
It's a great question. Yeah, to really identify the issue is that I think with the field, it's probably so large that it's not that specific. If it was a point catheter, it might have more relevance. But if this is a larger area, I don't know if it can tell us exactly where in this region to go, whereas RF probably has more specificity. What is interesting is when sometimes we get a big vagal response with Ferropulse, most people would give atropine. We actually repeat it again. And most of the time we can eliminate that vagal response, which does tell you there is some acute stunning of the nerves as well. But I do think it'd be nice to identify based on maybe PF, but I just think that the virtual electrode of that area is unknown. Come on one more time here at 45, and let me ask the group if they would do more here or do anything different on the left sides before we go to the right anterior. Come on here, please. Show me where I am anteriorly, please. Good. Would anyone do more or anything different around the left sides here?
I guess it seems okay, Rod. So I think you can pass the next station.
Okay. Off. Okay, we tried it again. I'm good with this. Okay. So no huge vagal response. We're going to go to the right anterior GP we've got about 20 minutes left to go. So this is where we expect to see some huge responses. We don't typically do a lot of LIGP. I'm nervous about that esophagus in a compassionate patient. I think we want to go to where the sinus node centers are, which is the right anterior GP. So we're going to move over to this region here now. And let's take a look here. And show us that fractionation map there again. And then we'll just observe the local potentials here. And you can see that we have the expected regions here, which are the anterior line of a wacka. And we're here at around 3 grams of force. We'll get a little bit more force here. And we've got these clear splits. And now what we're going to look for is some sinus acceleration here. And we'll just do probably like a 4x4 region. And I'll move slightly and then see. But let's just provoke the first one here and see. We got a beautiful split fractionated electrogram. I don't think I'm in the vein. Yep.
I'm not ice.
Go ahead.
I'm not very good at ice. Can you show us what does the ice look like in that region and that area that Lewis was saying is visible then in the SVC RA junction view? Can we see where your catheter is on the ice, and can you explain that to us?
Yeah, here would be the ice here that we're seeing. If Devi and Luis want to describe that there. But you can see across there, you have across from the SVC, which is really beautiful there. Devi or Luis, do you want to comment on that?
Yep. You can clearly see the SVC and the PA there in short axis and the SVC in long axis, which I think is like the junction. For me, that's like the trigone of the area that Luis was talking about.
Save that on ice.
Right.
It's a beautiful image there.
It's a beautiful image.
Yeah, just save that there. All right, well, let's go for it. Let's see what's going to happen here. We've got a lot of movement here with some respirations, but again, ice is the real deal in terms of what's happening in real time. My electrogram is the real deal in real time. Nothing's really changed. Let's come on ablation here at 40 watts, please. We're more of a septal structure. Yep. Our starting heart rate is 72. Okay. 79. Some movements here. 84, 86, 87. That's exciting. We see whitening there, right there in the ice, if everyone can take a see that as well. 88. That is exciting. I'm going to move just a hair on ice, and I'm really using my movements not on my mapping system, but based on ice. We're sitting here at 88. It seems like that's a pretty good response there. I'm moving back a little bit and going up and down. I'm thinking more of like a 3x3 here, or where I got that response. Maybe a little bit beyond in, just kind of moving. We're still sitting here at 88. Show us that little trigone region where it's all touching there. Great. I'm going to come down just a hair. My contact force is not very high. Go ahead and go to 50 watts here. I'm trying to get to an intraseptal structure with only 2 grams of force. Now I've got 3 or 4 or 5. We're going to try to paint this a little bit more. You can see now whitening on ice. Now there's a real lesion. That's great. We're kind of plateauing there at 88, which is interesting. Just painting this just a little bit above, maybe 1 lesion above and below where the good spot is. Coming a little bit anterior. I've got 6 grams of force, 50 watts in a young woman. Just don't want to steam pop here. We don't want to cause harm. And move in here, through here. Still plateaued right there. Oh, we got 90. We broke 90. That's pretty cool on someone that's baseline heart rate off and impedance is rising up here. Okay. So let's take a look at this and let's see what sort of durable response there is. Let's get some reaction from the panel.
So, Rob, I have a question for you. So, so do you want to produce an effect outside, right? The endo, or you want to ablate epi, transmurally, to affect the epi, because the GPs are there. So do you prefer to use high power, do that in a short time, or maybe lower power but long duration, to do more transmural?
Yeah.
But
I understand your question is obviously high power, long duration is going to be the best for that. That's why I'm kind of mixing it a little bit. I do it 40. I really need to see that ice get very echogenic there, and we were able to see it. I'm nervous about steam pops at 50 watts, so I'm kind of compromising here at 40 with kind of single-digit contact forces. So I don't have a great answer for you, and I know obviously the UPenn groups likes a low, slow cook, like 30 watts for 5 minutes. Sometimes you just need to get to 50, and you observe that on ice, and nothing happens until you get to 50. Can you go ahead and paste the CS at 500? We're going to rerun a snert just for fun and see what that snert shows after 1 lesion or 1 area at the RIGP. Let's run a snert real quick while we discuss. Yep. But we have a persistent response at 87. We touched up to around 91, which is really nice. I probably would reinforce a little bit of it here, unless the panel believes I should do something otherwise. But we're pacing right now, and I'm just curious to see what happens with the snert right now after 1 region of modification. So we've got about 30 seconds of the snert, and maybe we can, Professor Schilling, just talk a little bit more about whether we should do more here or whether we're happy with this response. We will definitely kiss these lesion sets from the right atrial side.
Rod, for our audience, can you just explain what your anesthesia is, what level of anesthesia the patient is in?
Level of anesthesia would probably be in between moderate, and moderate sedation. She's arousable, but she's asleep with propofol. And again, just for access, we did a 3 catheter study here. We've got a decapolar catheter and ice, all from the right femoral vein. And then you've got the ablation catheter. We're going to see something really cool there. Let's go to the review screen, fully review. We got 982 as our response. Subtract that. So already that's better. Subtract that from your baseline. And it's baseline 700. So the C snert now is 282. That's pretty cool. So the point is that many times we say that snerts indicate fixed sinus node disease, but I don't know if we know the amount of autonomic influence that this has. But I think we've clearly shown that we've shortened the snert here with just this. Should we do more here, Tolga? Would you do more in your lab and just do a couple more, or would you go to the right side?
Sure, I will do a little bit more. I will try to ablate all fragmented electrogram in that site.
Okay, I like it.
Not
Let's
take
do that
much
while there's more
time.
discussion. Let me just do a little more. Yep, come on, ablation here, please.
Can I ask,
I'm just going to reinforce
AV
these areas.
nodal
Yep.
behavior going to be interesting here? Is that going to change now?
Absolutely. You already see where I'm going. The question is, should we do the posterior medial left GP before we leave and do the CS the roof of the CS os from the left side, which I think is safer than ablating around the CS os on the right side. And see here, this is really nice. We are doing more ablation. It is whitening. We're here at 50 watts. I'm moving around with single digit force as to not create a problem. I'm not getting heart rate increases higher than this. I'm in the same region off, and I'm done there. I get to 90, I'm good there. I don't want to do more there and create a problem. So now what I'm thinking is what we should do is test the AV node ERP. So dial up that double that we did, Amy. It might be needed faster drive. See if we've changed anything with just RA GP modification. And I'm inclined to do just a couple lesions above the roof of the CS, which is the posterior medial left GP, if nothing has changed.
What I suppose part of the protocol for sedation is also avoiding pain, right? Because the patient is on sedation. So obviously, if the patient is feeling some pain, your heart frequency is going to increase. So because of that, it's very important to solve pain, but to assure that your response, your increment in heart frequency is sustained. You know? Even after patient.
I totally agree. You're going to get a sympathetic response if they're in significant pain. The good thing is there's no overt signs of any awareness of that or any reaction to this.
Okay.
And here we're trying to do some AV node ERPs. Let me put the CS where the His catheter is, please. Let me just record a His. We're just taking our decapolar and pushing that in different areas here and seeing if we could record a His here with our deca.
So
there's a His there.
In terms of predictions, what are the variables with the highest prediction value of response? It says refractory period of the sinus node, increment on heart frequency. What is the cutoff for better prediction of better response? What do you think based on your experience and the others in the back?
So I think the most important limitation of the CNA is endpoint. For example, the extracardiac vagal stimulation is not an answer because look at that. The rod completely increases the sinus rate after one RF point in the right superior GP side. This is why we are seeing the similar acute success by using vena cava superior ablation, just right-sided ablation. The issue is,
Amy, go for it.
as an acute effect, we are just ablating nerve fibers, not true neuronal bodies or epicardial neuronal bodies. So I'm not sure, but if you use fragmentation as your mapping method, you should ablate fragmented electrogram to be sure about success. If you use 3D CT and epicardial fat pad as your mapping method, you should ablate all EGM in that site. So it depends on which mapping method to use. For example, if you use high frequency stimulation, you have to show complete elimination of high frequency stimulation response after the ablation.
Got it.
And the other issue about anesthesia, at the beginning, we just use mild or moderate sedation because the people wants to see some huge vagal response. I'm sure Rod tried to do that. Why he used such a mild or moderate sedation, but I think we don't need to see huge vagal response in all cases because we have too many data about the right side for left superior GP, left inferior GP. We already know their anatomic location, so we don't need to see very huge vagal responses in all areas. So I totally use general anesthesia in all cases to prevent any problem in mapping.
We're gonna go to try to assess AV node ERP, Dr. Schilling, because we're keeping it old school today with basic EP, which is kind of a lost art, as a lot of focus is on technology, which is great, but we can't forget the EP stuff. So here, we're trying to just assess AV node ERP. We're pacing here. We've got a nice AH, which actually looks relatively short with the review screen. Let's keep going here. Let's just assess if anything's changed with AV node ERP. And again, we don't typically think it should be. A lot of fibers are mixed, but we really believe the predominant centers of AV nodal control are more around the CS ostium. But it'd be really nice to show that something could change here. And while we're doing that, let's just show ice, Chris Woolley, and make ice the full screen. I'm just going to show you what a catheter should look like if you're ablating the posterior medial GP from the left side. This is what we do for left-sided slow pathway modification. You could see the CS roof slightly. You get a little bit of a curve on it. Let me get you a better image right there. You could see the CS os. And this is a region that I think is relatively safe here. And I would probably lay down a couple lesions here. But let's take a look first at what's happening in the EP study, because it would be nice just as a checkpoint to see if we've changed AV node ERP. Currently, we're conducting down 600, 310. Oh, didn't we need doubles or no? Okay, keep coming. Great. You can see on the extras that it's hard to see the hiss because things move, but we can certainly still keep our eye on the AV conduction, and we still know when there's refractory period. 600, 280. Keep bringing that down. Great. 270. Why don't you go down by 20s, just so we can move things along? We've got about 6 minutes left. No matter what, we're going to go ahead and reinforce a little bit on the side because these are paraseptal, and we really need to get in between the SVC, the aorta, the RA, the LA, and Waterston's groove. So we're going to go ahead and do facing lesions across there on the SVC side. And typically we'll see another 5 or 10 point increase. We don't want a runaway sinus. Oh, that's atrial ERP. So why don't you do 633? But we don't want a runaway sinus node, so we typically will stop around 90 some beats per minute. The other thing is that sinoatrial artery injury has been reported, and we had 2 of those cases in the multi-center as well. So getting overly exuberant around the SVC is also ill-advised. That blocked right there?
Can I just ask?
Good. So that's 600,
Can I just
300.
ask very quickly?
Yep.
We often
Sure.
see an autonomic effect after slow pathway ablation, and obviously maybe we're affecting the right inferior area. Is ablating in the region of the slow pathway or the CSOS anything that you would do in these types of cases?
Well, that's what I'm thinking right now is this is a left-sided slow pathway location here. And I'm thinking if Winky Bach is that poor and she was Winky Baching at 500, let's go ahead and repeat Winky Bach right now. We're getting variable AV NERPs. Just go ahead and paste ablation distal at 500. And let's see if she conducts 1-to-1. And we've got a beautiful hiss on CS distal 1-2. Good. She's 1-to-1 with a short AH, which is pretty cool. We have not given atropine. We have not given isoprel. Come down to 5. Well, you're at 500. Walk it down by 20s. That's 480. Next. 460. 440. Love it. Can we get to 400? We can get to 400 1-to-1. There you go. There's block right there. So 380. So we've improved Winky Bach by about 120. And that is interesting because we don't typically think about the RAGP affecting this. But I think most of these are mixed fibers and all of that. I'm right here. I'm going to do 1 lesion right here. And I like what's happened there, but just because I see how much dual AV nodes she has, we don't see any echoes anymore, by the way. Let me do 1 lesion. We're going to go to the RA side. Go ahead.
While we're doing,
Come on, 40
while we're
watts
doing
here.
that, let
We're
me
just
just
doing the
ask.
posterior medial.
Yeah, while we're doing that, let me just ask the panel. So I really believe in this because I had a 20-year-old athlete present with a post-viral syndrome, was having to give up his sport because he was fainting every day with autonomic faints. And I passed him on to my colleague Boone Lim, who's an expert in this area, and he did this ablation, has completely transformed this patient's life. I mean, do you see this as a sort of feature of a post-viral syndrome very often, guys?
Off.
Sorry, which patient? Do you ask for which patient?
So So
Could this be post-viral
think-
autonomic?
post-viral,
Viral,
yeah.
Okay. Luis, do you want to say something?
I just wonder whether
Well,
you,
I
this is
don't believe-
a clinical picture that you see very often.
According to my experience for CNA, especially for if we do this procedure for pure vasodepressor reflex syncope patients, the syncope recurrence will be higher because we have just partial effect on other component of the autonomic system.
On
So
ablation
I'm
here?
not sure it will work very well in that population because very limited data, maybe just a couple of case reports. I don't know.
Sorry, I couldn't hear about what type of patients do you refer.
So Lewis, this is a 20-year-old who's never had this syndrome before, presents after a viral illness and had to give up his professional athlete career because he was fainting all the time. And he had this procedure and he's completely back to normal. It's, I mean, incredible.
Before this,
I would agree, Professor Schilling. Some of the most dramatic things I've been involved with in this awesome field have actually been cardioneural, like life-changing. We had a patient drive here from Michigan with a pet chihuahua that was barking to be able to signal syncope, was wearing a helmet because he was syncopizing every single day, and now is doing incredibly well. This is actually some people that truly have malignant vasovagal syncope. The quality of life is just incredible.
Yeah, we're seeing the same effect in quality of life in the numbers of symptomatic episodes. So we are seeing that those symptoms decrease a lot, the episodes. So we're really believers on the procedure. But one important aspect is the selection of the patient, right? Because obviously the patients that are not going to be better are the ones that have vasodepressor response mixed with total cardioinhibitory symptoms. So we are trying to be very careful with the indicator.
Well, we're coming to the end of our session, so perhaps I can just leave Rod to give us a brief summary and a last word.
Beautiful. Take a look at the ice there. We've done some reinforcing lesions there on the RA. You can see that what it actually looks like is we're ablating just north of the limbus, and you can see that there's some echogenicity just above as we're pulling down from the SVC towards the limbus. We've faced those lesions there. We're still around 85 beats per minute. We had some transient accelerations to 90. What I would do is give atropine. I don't want to over-ablate this and risk sinus node injuries. I would give 1 milligram of atropine if we could do that. We could always tell you later on Twitter, and then see if there's a response. What's remarkable is sometimes there just is no response to atropine. So if she sits there around 90 or high 80s, then I feel like we've done pretty good. But I think in summary, we didn't find LSGP vagal responses, but in a very localized region, we've clearly been able to change autonomics. C-SNRTs changed, Winky box changed, resting heart rates changed. We're pretty happy.
Brilliant. Well, that's an amazing case. Thanks, Rod. And thanks to the panel for educating me on this fascinating area, which I think is really important. One of the audience asked about anti-bradycardia pacing, and I think that that's really failed to show any significant impact in randomized trials. And obviously pacing is something one wants to avoid in such a young patient. Let's go on. So thanks to Devi, Tolga, and Luis for their great insights. There's still plenty more to come on day 2 of RIO, and the next session is starting in just a moment. So come back soon.